Great, thank you, MF, and thank you to the organizers for the invitation to give this talk. Disclosures. So tobevibart is an investigational Fc engineered human antibody that's directed against a conserved antigenic loop of hepatitis B surface antigen that has multiple potential mechanisms of action. So one is binding of virions and inhibiting viral entry into hepatocytes. Another is binding to subviral particles in virions and clearing them from the system. And then third, a potential immunomodulation effect. The Fc domain has been engineered to incorporate the Gali mutation, which preferentially binds Fc gamma 2A and 3A receptors to activate T cells. So in terms of this kind of T cell activation, these immune complexes are formed, and then, as I said, they preferentially bind the Fc gamma 2A and 3A receptors, as well as the inhibitory Fc gamma 2B receptors, activates these antigen-presenting cells, and then generate effector T cells, which we hope would lead to more durable HBV-specific immunity and potential functional cure over time once the drug is gone and the antibody is gone. So this has been studied over the last several years, and so this was initially presented back in 2022, where we evaluated 4 different doses of tobevibart at 6 milligrams, 18 milligrams, 75, and 300 milligrams. And as you can see, with each of those doses, there was rapid declines in mean surface antigen levels, with a peak decline of about 2.2 logs with the 300 milligram dose, with maximum effect around day 8. At nadir, 23 out of 24 participants, or about 96%, randomized to receive tobevibart had surface antigen levels of less than 100 IUs per ml, including those that were dosed at 75 milligrams. In addition, 5 out of 6, or 83% of the participants randomized in the 300 milligram group achieved surface antigen levels less than 10 IUs per ml at nadir. In addition, we also, as part of this study, looked at participants who were not on nuke therapy, and so they had HBV DNA production. And as you can see, giving a dose of tobevibart with the decreases in surface antigen that you see in yellow, we also had corresponding decreases in HBV DNA as well at both the 75 and 300 milligram dose levels with tobevibart. So the next study we conducted was the 1001 study, which looked at siRNA monotherapy with pegylated interferon for 24 weeks, and then a couple cohorts up to 48 weeks of treatment. So in this cohort, as has been highlighted previously today, we saw that at 24 weeks, only 5.6% of participants were able to achieve seroclearance. However, at 48 weeks, 4 out of 13, or about 31% of participants, were able to achieve seroclearance, and then at any time, and then off treatment, 15 to 16% of participants were able to maintain seroclearance off treatment. So basically combining the siRNA, which, as was mentioned before, basically 0 to 5% of participants receiving monotherapy with siRNA are able to achieve seroclearance. Combining that with interferon alpha, which again you expect probably 7 to 10% achieving seroclearance, we were able to get a much higher percentage of participants achieving that with that combination. So basically 24 weeks of the combination of SI plus interferon was not sufficient to achieve surface antigen loss. However, 48 weeks this suggested some promise for longer durations of treatment. So the next study that we conducted was the MARCH trial. And so this is a phase 2 trial evaluating combinations of tobevibart, elebsiran, siRNA, as well as pegylated interferon alpha. So part A of the study was just to evaluate the safety of the initial combination of siRNA with the antibody. And so in this group, we had one cohort that had a lead-in with elebsiran followed by weekly doses of tobevibart. And then we also had another cohort that started both at the same time. And they received that for about 12 weeks. Again, this was mainly for safety and just to look at some initial kinetics of surface antigen loss. So what we were able to observe here is that This is looking at the lead-in with the siRNA followed by dosing with the antibody. At end of treatment, by about week 20, we saw about a 3 log decline in surface antigen levels. However, in the cohort where we started both at the same time, again, we saw almost a 2 log decline within 4 weeks of initiation of the therapy. And then based on the length of the curve, the slope of the curve, you would expect if we continue dosing beyond 12 weeks, we would probably get to the same level at week 20. So basically, the lead-in versus giving both at the same time didn't appear to make any difference in terms of getting to maximal surface antigen declines. And then once therapy was stopped, we saw a fairly rapid increase in terms of the surface antigen levels. However, even up to 48 weeks after stopping therapy, the new set point for surface antigen was still about a log lower than what these participants were at baseline. So basically, even with these short courses with this combination, 90% of the participants achieve surface antigen levels less than 10 IUs per ml. None of the participants achieved seroclearance, and then we had this gradual rebound after end of treatment in all the cohorts. So here, with just 12 weeks of treatment, we did not have any participants achieve seroclearance. But we did see, very rapid declines of surface antigen up to 3 logs. So then the next part of the MARCH trial is part B of the trial. And so this is looking at 24 weeks of treatment with the combination of elebsiran with tobevibart with and without pegylated interferon alpha. So in terms of and this was presented last year by Ed Gain at AASLD. And so here you can see, going back to the data that we had from the elebsiran plus interferon alpha, with 24 weeks of treatment, we only had one participant, or about 5.5% of participants achieving seroclearance at the end of treatment. However, when we added the antibody on top of elebsiran with or without pegylated interferon alpha, we got 3 participants in each of those cohorts that achieved seroclearance at the end of treatment. So we went from about 5.5% to 15% with the addition of the antibody in terms of those participants achieving seroclearance. As you can see, these were preferentially seen and observed in participants that had lower baseline surface antigen levels of less than 3,000. None of the participants that had baseline greater than 3,000 achieved seroclearance. And then most of these participants, after stopping therapy, did rebound. Only 1 participant at their last post-treatment visit had sustained seroclearance out of the 3 in the regimen that contained interferon alpha. In addition, we looked at anti-HBs antibody levels by cohort. So looking at the interferon plus elebsiran on the far left, positivity is considered a level greater than 10 milli-IUs per ml. So there was only a couple of participants that had met that criteria. But then if you look at the cohort that contained pegylated interferon alpha, you can see there are much higher levels and higher proportion of participants that were positive for the anti-HBs antibody levels. So arguing that interferon alpha is contributing to this and may be an essential component as part of this immune activation. So the other cohorts in the MARCH trial are looking at 48-week cohorts of either elebsiran plus tobevibart or elebsiran plus tobevibart plus pegylated interferon alpha. And so the question is now, what will we see? So if you look at the elebsiran plus pegylated interferon at 24 weeks, we had 1 participant achieve seroclearance, but at week 48, we had 4, or about 31%. So we had a fairly large increase in the proportion of participants that were able to achieve seroclearance with longer duration of treatment. The question now is, if we add on the antibody, which will drive surface antigen levels down faster and earlier, will 48 weeks of treatment also allow us to see a similar increase in terms of seroclearance rates from what was observed at week 24 to week 48, as we had seen with the just elebsiran with pegylated interferon alpha. So this data will be presented as a late breaker at AASLD next Monday. In terms of safety, we've done a pooled analysis across 4 different clinical trials in about 121 participants who have received tobevibart and elebsiran combination together across our hepatitis B and hepatitis delta studies, so about 100 in the hepatitis B studies and about 21 in the delta studies. And majority of the treatment emergent adverse events were grade 1 or 2 and transient. The most common drug-related treatment emergent adverse events were influenza-like illness, chills, and headache. There were 2 SAEs that were reported, one that was reported related to tobevibart, that was neutropenia, and then an unrelated SAE of coronary artery disease and acute cholecystitis. And there were no treatment emergent adverse events that led to tobevibart or elebsiran discontinuation or death. And so this is a poster presentation that we will have also at AASLD looking at the pooled safety analysis across the different trials. So in summary, single doses of tobevibart in viremic patients resulted in rapid reductions in surface antigen as well as HBV DNA levels. Tobevibart monotherapy demonstrated rapid reductions in surface antigen, but rebounds occurred after cessation of therapy. Combination therapy of tobevibart and elebsiran for 24 weeks resulted in about 3 log decline in surface antigen levels, with 90% of those participants achieving surface antigen levels less than 10 IUs per ml at end of treatment. 24-week end of treatment data showed that the addition of tobevibart to elebsiran with and without pegylated interferon alpha increased seroclearance rates almost 3-fold compared to what was observed with just elebsiran and pegylated interferon alpha. And then from a safety perspective, the aggregate safety suggests the safety of the tobevibart and elebsiran combination is generally consistent with what you would observe with each of those class effects for those therapeutics. So I think the ultimate question, which Ed will be presenting next Monday, is will 48 weeks of combination treatment with tobevibart, elebsiran, with or without pegylated interferon alpha increase our surface antigen seroclearance rates as seen with elebsiran plus pegylated interferon alpha? So this is just highlighting additional data that we will be having at this next week with tobevibart and elebsiran. We have, as I mentioned, the late breaker oral with the March study. We also have an oral presentation looking at week 24 data from our Solstice hepatitis delta study with this combination, and then others looking at the safety profile as well as renal impairment studies as well. So with that, thank you for your attention.